The biggest issue that I see in this case is not going to be the infraocular nerve, how large the crowns are, whatever the case may be. The biggest thing that I'm looking at right now is going to be tooth number 31, or if this is international nomenclature, it's going to be tooth number 47. Yo, what up guys? I'm Dr. Jared Williams, and if you're new to this channel, I just want to let you know you're in for a surprise. So before we go further, as a matter of fact, let me pause now. Let me introduce myself. I'm Dr. Jared Williams. I'm a concierge dental surgeon out in Houston, Texas, and forgive me, I have a little cold. My daughter got me sick. No, it's not COVID. I already got my check, so I'm good here. So if you hear a little nasally in the background, don't be alarmed. And a little snorting. But I just want to let you know I'm Dr. Jared Williams. I'm a concierge dental surgeon out in Houston, Texas, and all I do is focus on extractions, implants, and coaching, and also IV sedation. So if you are a doctor or a patient that is just like, man, I like what you're doing, what I want you to do is hit the like button, smash subscribe, because you know the information I'm going to give you is going to be simple and that you could understand and that you could either apply into your practice and also learn from the patient's perspective. So I just want to say welcome, welcome, welcome. Now, I want to give you some insight today. I was speaking to one of my coaching clients, and Dr. Jenkins out of Georgia, and he sent me this x-ray, and I wanted to go over this with you because, you know, it's so important that when you're gonna smile after surgery, you got to look at everything and be prepared for every little twist and turn. So when he sent me this x-ray, I'm gonna put it up here. And when he sent me this x-ray, as you can see right here, this is a tooth that he's looking at. It's tooth number 32. Now, for most individuals, this tooth would be like, it would look pretty routine. Now, it's not the most diagnostic thing because I see the infraocular nerve here, but I would rather trace it all the way up where it's entering into the mandibular canal. But anyways, this is what he sent us, and so this is what we're going to discuss today. So I'm going to give you some tips and tricks on what to do. So number one, we got to look at the patient's medical history, got to make sure what the patient's chief complaint is. We got to make sure that anything that we're going to do is not going to make our task that much more challenging, getting this tooth out. And so by getting the patient's chief complaint, getting the patient's medical history, just making sure that it's not going to screw us up later down the road, these are certain things I want you to take into consideration. All right, so right off the bat, right? So when I look at this tooth, number one, these crowns are pretty bulbous, right? But that's not even a concern. You're probably thinking, okay, doc, if you've been watching this channel, you know, okay, you're gonna look at the infraocular nerve. Well, that's not even the big issue, all right? The biggest issue that I see in this case is not going to be the infraocular nerve, how large the crowns are, whatever the case may be. The biggest thing that I'm looking at right now is going to be tooth number 31, or if this is international nomenclature, it's going to be tooth number 47. And the reason why I say that is this. If you follow this channel, you know that I love to highlight elevating of crowns. That's going to be the number one way in which you elevate the teeth, because that's going to be the number one way in which I like to remove these types of teeth. Now, I'm not quite sure if this is soft tissue impacted or there's some bone on the distal aspect of this crown, but I'm going to show you what happened to him, and I'm going to kind of give you an idea of what you could do moving forward. So number one, when you see a tooth that you're going to be taking out, it doesn't matter if it's a third molar or any tooth in the mouth, if it's sitting next to a crown, always, number one is let the patient know, hey, there's a likelihood that when we're taking out this tooth, this crown can pop off. It looks like a gold crown, to be exact. Don't ask me why, I just know dentistry. I haven't seen the patient a day in my life, but it looks like a gold crown. And if in fact this crown snaps off, then what we could do is just go ahead and place it, glue it back on, and then everything's good. The patient understands, you understand, so you know that you're going to be that much more patient when you're going to be treating this case, right? Treating this patient. So that's number one. So automatically, I have the patient prepared for if the crown comes off, and I have myself prepared if the crown comes off. So I'm not like, oh crap, I should have told the patient. So you got those things taken in consideration. Then it's the next thing is this is like just gonna have to be patient. Number two is just you're gonna have to just be patient, because one thing I learned about taking out teeth, it's not about how difficult the tooth is or how easy it is. It's about just getting the tooth out. And I found that it doesn't matter what type of imaging you have, if it's going to be a pano, PA, or even a CT scan. You're not going to really get too much information until you're in the actual tooth, because when doctor was working on this case, he was just like, man, doc, I had such a hard time. As a matter of fact, he called me at, what is it, like 5:30, 5:40. I'm pretty sure that's when you dismiss a patient, because then you'll see the x-rays after. So you don't know what's going to happen. So I don't care what type of imaging you have, it's not going to necessarily help you in this case, because there could be some factors that you're not aware of. So with that being stated, I would want you to elevate. I would never want you to start sectioning this tooth, right? If you've taken my course, for all those who haven't, feel free to go in the description down below, take the course. It's going to take your skills to the next level. But anyways, by elevating this tooth, you're going to allow the periodontal ligaments to get loose. Anytime you're taking out a tooth that is in contact with an opposing tooth, you know that the PDLs are going to be mature, and it's going to really try to hold that tooth in. And then it's a bulbous root. And then on top of that, it's like one of those wide roots, and then it's actually been in function. So those are all the things that are going to be taken into consideration. So I would literally just try to elevate this tooth, or just stay on it as long as I possibly can, at least 5 to 10 minutes of just elevating, putting a forcep on it, and just rocking it back and forth, just to kind of just expand the bone. Because in these types of cases, I don't think he even got this tooth out. Yeah, I'll show you, he didn't get his whole tooth out. But he's literally just probably was rock solid, didn't go anywhere, probably thought it was fused to the bone. I don't think it was, even though that the PDL is very thin back there. But it's just one of those things of just patience. Like, some of these teeth are gonna fly out your head in like 2 seconds flat if you've taken the course and you've following the type of principles I'm telling you. Others, you're just gonna have to be sitting there literally watching TV. Like, I got this big old 55-inch sitting right in front of me, and when I'm in surgery, I'll literally just be having my Minnesota in one hand and my elevator in the other, and I'll just be watching TV. The patient's looking up at me like, well, I don't feel pain, so I'm good. And so the assistant's just like, what the heck are you doing? I'm like, well, why don't you mind your business? I'm doing my job, you keep suctioning. And so I'm just literally just wanting to expand this tooth out, because I know that if I fracture this crown off, I don't know if I'm gonna really be able to get the movement on this root. So I'll just sit there for literally like 3 to 5 minutes, maybe even 10 minutes, just elevating, 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 elevating. And so that's super important when you're working on these cases, because if you're not, what's gonna happen next? You're gonna look at this tooth, and you're gonna be like, oh, this is pretty straightforward. Oh, no issues. I'm not by the inferior nerve, which is right here. All is well. You'll get one of those. And this, my friends, is a confidence shaker. And the reason why I say it's a confidence shaker is because you're gonna be operating on this tooth, and literally what's gonna happen is you're gonna start cutting. You're like, doc, I followed exactly what you said in the course. I did the sectioning just like you did, so many millimeters of the furcation. I elevated, I told the patient about the crown. It even looks like the crown came off. I told you, look, there's a crown here, no crown here. So I didn't even prepare for this either. I didn't look at this, I didn't study, I just said, send me the x-rays. And I told you, what time is it? Today is October 5th. He sent me this October 4th at 5:30. He called me saying, hey, doc, man, I had a hell of a time. The reason why is because probably didn't have enough patience required. And that's one of the first things I tell you guys, like, don't try to be in a rush to get these teeth out. It's not about how fast you get them out, it's about how smooth you get them out. Because if you're fast, you're gonna end up screwing something up. And hence, he called me, he was like, oh my goodness. Now, I just wanna let you know, Dr. Jenkins is no slouch. He's doing a fantastic job. He's doing a fantastic job. I just want to let you know, guys, he's doing a fantastic job. And I want to let you know, I've been in scenarios where it's taken me at least an hour and a half, 2 hours just to take out one tooth, because I found myself in a scenario like this. Now, it doesn't happen anymore because, I've followed these principles I'm giving you, like telling the patient that their crown could come off, elevating for at least 5-10 minutes, especially if I know it's like one of these crowns. I'm very seldomly going to put a burr on these types of teeth until I absolutely have to. And as you can see, you got the crown that popped off, and then trying to section the furcation, when these roots are literally fused together. You have these bulbous, thick-sized roots, and you don't know what the apices of these roots look like, because most times they end up doing one of these and they're fused. So there's bone over here, bone locked over here, and so when you're trying to take that tooth out, it's not going anywhere. So literally what you have to do is just sit there and just be patient. And then probably lost some confidence when he's working on this tooth, because it's like, man, I'm sectioning, I got pacification like you told me, doc, but it's still not working. Well, guys, it's not if the tooth's gonna come out, it's when the tooth's gonna come out. And so it's all about just taming your patients. Like, patients ask me all the time, they're like, hey doc, how long is it gonna take? I'm like, I don't know. And I've done 10,000 cases, and they're like, well, but I tell them, hey, it's routine. And I just let them know, hey, I've done this several thousand times, and it's not about how fast I get out, it's that I get the tooth out. And so, but what I'm gonna tell the patient is this, I'm gonna make sure that they know everything that's coming down the pipe, so that in their minds, they're not literally going through torture as I'm going through torture myself, trying to get this tooth out and really try to work that thing out. And so I wanted to give you insight on, what's going on in this particular case. And I was actually just telling you exactly what's happened before. I promise you, as God be my witness, I have not studied this case. And so once again, let me just kind of give you a backtrack. You see, here's the crown intact right here. The crown is actually intact over here. In this one, it's broken off. So I'm pretty sure, like, okay, you told me all the bad stuff. Now what about the good stuff? All right, the good stuff is this. The crown is actually shorter, so it's gonna be that much easier to section these crowns. So when I'm operating in a case like this, one thing I wanna do is just reassure the patient, just let them know, hey, tooth's just taking a little bit more challenging. We're gonna do the best we can to get you taken care of. Are you feeling any pain? And just reassure them, hey, it's gonna be a lot of pressure. And then oftentimes at this point, I really will adjust what my expectations are on this tooth, and I'll actually adjust the way I sit. So like I said, I literally will sit down when I'm doing cases, and to just make sure that I'm good. I hope y'all can see this right here. But I'm sitting down operating like this. Sometimes what I'll do is I'll lean forward and really make sure my back and neck are straight when I'm operating. Because when you're at a case like this, typically what happens is if you're standing, you're hunched over, your shoulders are up high, up close to your ears. That's not a good place to be. And all your muscles are gonna be torn up. And if you don't exercise on a daily basis, doctors, what's literally gonna end up happening is you could have some really, really significant challenges, like some cervical fusions, or have some brachial plexus injury, because everything's so tight. And so at this point, when all hell's broken loose, now it's just time to relax even more. Now you're probably saying like, hey doc, this is probably counterintuitive. Well, if you've taken out as many cases as me, then you tell me what to do. But if you haven't, be quiet, close your mouth, continue taking notes so that you can smile after surgery. So with that being stated, now it's time for you to just sit back and really just relax. And what I like to do is remove all the instruments that I'm not using out the way, and just kind of take a breather. Sometimes if we've been there for a minute, I'll take a PA like this, see where we are, reorganize myself to make sure we're kind of like starting over, treating it as if the patient came to me from another doctor. And when that happens, everything just blows by. So number one is this. I will go ahead and grab my handpiece, and I'll take my burr further down. What happens in this case, he's about 1 millimeter or 2 down. He's sectioned. If he puts his elevator, and my favorite elevator, I'm not gonna tell you, you have to watch other videos, but I get my elevator, if I were to end up trying to section this tooth, this root from this root, only that's gonna happen is this part of this tooth, this dentin is just gonna flake off. And then you have this wider piece, this V shape here, and that's not gonna do anything. So in this particular situation, I would take this burr all the way down to here, right? Get at least 4 to 5 millimeters, because once it happens, you can literally snap it, right? Once that's done, hopefully you get some movement. If not, then typically I would take the burr and do the same thing on this side. Go all the way down here. There's about 3 millimeters of bone from here to here. That's a tremendous amount of space. So what I would do is I would actually not cut the bone, I would actually cut the tooth. So I would end up putting my burr this way. Refrain from putting the burr on this side because there's nutrient vessels that will end up causing you to have a bleed, and then it just clouds up all this space up here. So just be aware of that. But I would put a cut in here going buccal, lingual, just like I've told you before in previous videos, and do the same thing on this one. But I would do this one first and see if I could end up breaking it into 2 different individual pieces. If that didn't work, then what I would do is I would take the burr and not cut here, but I would cut here on the actual tooth. And then I would just start over as if I'm elevating this tooth. And typically by doing that, what's going to end up happening is you're going to end up being able to loosen the PDL, kind of like because you're starting all over. Because when you start fracturing off all the crowns, it's like there's nowhere to get a purchase point, there's nowhere to get a fulcrum, there's nowhere that you could get leverage so that you could ease this tooth out. Another challenge that I found that is a pain in the butt with these teeth is that there's going to be a lip of enamel and dentin on the buccal or lingual, mesial or distal. But I'm just gonna focus on the buccal. So when you're working on your tooth, here's your tooth and it's underneath the bone, right? So if I were to say, here's your bone, here's your tooth. All right, so if I'm working on, here's the tooth that we're looking at right here. So here's the buccal bone, my hand over here. So it's pointing towards me, right? I can't see this actual tooth because it's down here. Well, what happens is this: sometimes there's a little bit of bone that is coming up against this buccal plate, and I can't see it because either it is bloody in there or I've sectioned the crown or the tooth so much where I can't see anything. So I literally peek in and it looks as if it's just a crater of just tooth just kind of sectioned up. Sometimes what happens is that little piece of tissue, the little piece of dentin or tooth, if you were to get your root tip picks and slide kind of like you're going in between your nail and just slide your elevator in between the dentin or the tooth and the bone and just slide it out and be sure not to fracture off any dentin, what literally ends up happening, that'll be the key of taking this tooth out. Now that may be a little, you're gonna have to conceptualize that unless you come and just observe me in office. But sometimes that's one of the reasons why these teeth are out, because you're in them sectioning and that part of that tooth is just stuck to the buccal plate that you're looking down, but you can't see it. And what ends up happening is this: it's just like, oh man, I'm so tired, let me just refer this out. That's not the time for you to refer it out. It's time for you to just breathe, take action, and just be aware that sometimes it could be on the buccal plate or the lingual plate, and all you have to do is get your elevator and slide it in between the tooth and the bone and just kind of go slow without fracturing any tooth pieces off. And by doing that, you're going to get between the bone and the tooth and really start breaking up those PDLs all over again. And at that juncture, ladies and gentlemen, that's when everything starts settling down. And so I want to recap one more time. With these teeth, it's all about getting the tooth mobile from the root. It's not about how fast you can take these teeth out, because like I said, when the roots are conical, everybody say those teeth are real easy to take out. No, because those are the ones that look easy. All right, so remember, like I told you, what looks hard is often easy. I'm telling you, there's certain times where these roots will look easy, but it's like, what the heck did I get myself into? And so I'm giving you these principles so that when something looks easy, what looks hard is often easy. And so it's not what looks easy is easy, because that's not the case. What looks hard is often easy. And so I want you guys to approach each case as it is super challenging. And you follow these principles and you go like, oh, because I'm pretty sure a lot of you guys, what happens is you either did residency, you did finish dental school, you got a couple of success, and you're like, oh man, I could take out everything. No. What I want for you to do is take it slow and expect everything is challenging. Like I said earlier, when my patients come in and say, hey doc, this should take 5-10 minutes, I'm like, maybe an hour and 30 minutes. And what I'm doing there is I'm setting the expectation, not just for them, but for myself. Because if I say, there's been times in the recent future, I say, oh, this is gonna take me 10 minutes, and it's easy to, in my mind. This thing takes me about 45 minutes. I'm like, oh gosh. So I'm like, crap. So I want to readjust your thought process. When you're going to be taking out these types of teeth, or any tooth for that matter, be aware of your entire surrounding, because by being aware of your entire surrounding and setting the expectations earlier on, it's going to allow your process within oral surgery implants to go that much smoother. So remember, guys, I want you to remember what looks hard is often easy, all right? So I want you to make it a great one. Before I let you go, if this information was good, or if you felt that, hey man, I really learned something, share with me in the comments down below. It seems like a lot of patients are hitting me up, and I want to hear from some of the doctors that are out there, kind of balance it up, because I want to see if this information is benefiting you in any way, form, or fashion. And if it is, let me know. Send it in the comments down below. If you're like, hey, Dr. Williams, you're really not getting me exactly what I want, well, send me a message. You can email me, email my team, and we'll go over a case that you want to discuss. I don't necessarily always do this, but I want to just open up the opportunity so that you can take it to the next level. And then if you're like, hey, doc, I see what you're doing. I like what you're doing. I want to take my skills to the next level. Feel free to go in the description down below, sign up for the courses, see how we could get you to go into the next level. We're going to be offering live hands-on courses in the near future. So just continue to subscribe with us, so hit the notification bell so that you can get an idea of what's going on, so that when an opportunity presents itself, you're able to jump on it and take advantage. All right, guys, so there you have it, guys. I'm Dr. Jared Williams, and my focus is for you to smile after surgery. Make it a great one.